Good morning and welcome to the GW Epilepsy Seminar Series. It's my great pleasure this morning to introduce Dr. Anton Bagic from University of Pittsburgh. We haven't had a talk on magnetoencephalography, and Dr. Bagic is one of the world-renowned experts on this subject, so we're looking forward to his talk. Dr. Bagic is professor of neurology at the University of Pittsburgh. He also is the chief of epilepsy there and the director of the epilepsy monitoring unit. He also directs the magnetoencephalography epilepsy program and is a scientific advisor for MEG research. He received his MD and master's and PhD from the University of Zagreb in Croatia before he pursued a research fellowship in molecular biology at the Uniformed Services University in Bethesda, followed by neurology residency at Georgetown and clinical neurophysiology, epilepsy, sleep, magnetoencephalography, and clinical research fellowships at NIH. He is one of the 5 founders and a past president of the American Clinical MEG Society and chair of its Clinical Practice Guidelines Committee that published the world's first clinical practice guidelines for clinical magnetoencephalography. He serves as a board member of the National Association of Epilepsy Centers and is a fellow of the American Epilepsy Society. Dr. Bagic's practice is focused on epilepsy and clinical applications of magnetoencephalography, and his research involves all different aspects of epilepsy research, epilepsy care. He has published over 140 articles and abstracts and book chapters. Please welcome Dr. Bagic.
Thank you very much, Dr. Kubesi. This is a distinct pleasure to be in this place, particularly for me, since, as you just stated, I trained in this city and I got inoculated with MEG virus about 7.5 miles north from here, as I was training with Dr. Susumu Tato, who was one of the pioneers of MEG in the world. As you see, my talk is titled Not So Benign Neglect, Underutilization of MEG in Epilepsy Surgery. I'm going to go first through a few of these obligatory slides that Dr. Kubesi's shop requires for him to stay kosher and ingratiate gods of CME and all that good stuff. My learning objectives will be stated in my presentation per se. I would like to make a few disclosures at the beginning. As you can probably discern from this slide, I have 2 professional passions. They are epilepsy and magnetoencephalography, and all my professional allegiances are related to these 2 fields. As you see, I state here that if I use some brand names, their use is unavoidable, and that doesn't reflect any endorsement of any specific brand or product. I do take images liberally from the web, and if you ever found anything useful I created, please do use. Here are actually learning objectives. It's really my goal that everybody who engages in this communication today understands basic principles of MEG, and particularly how it's related and how it's complementary to well-known EEG. I also would like everybody to be able to identify evidence-supported indications for considering MEG in epilepsy surgery. Furthermore, I would like to stimulate all of us to engage in a dialogue and consideration how we can use MEG in order to kindle surge in epilepsy surgery. Here's an outline of my talk. There is no need for me to read each of these segments. Some segments, by the way, will be slide or 2, but they are included as separate segments because the topics are important to bring on your radars. Those of you who read 2012 IOM report remember how we were surprised that it stated we had 2.2 million of people with epilepsy in America. And Dr. Kubesi was startled in particular because he used to write in his grants, as I did, that we have nearly 3 million people with epilepsy. Guess what? We were wrong. We apparently have about 3.5 million people with epilepsy. Many of you in the audience have heard for this 1 in 26, but let's bring 1 in 26 to reality. If you local guys attend next sold-out Steelers, I'm obviously from Pittsburgh, Redskins game, right? You will be surrounded by about 3,200 of people who statistically will develop epilepsy at some point in their lives. Don't you find that startling? But what is important from that IOM report in 2012? Less than a quarter of people with drug-resistant epilepsy were seen by an epileptologist in a prior year. That is a regrettable reality that we have to change. Furthermore, who suffers most is people with uncontrolled seizures, whose risk of dying is 8 times higher. And during this very hour, by the time we finish our dialogue, 5 people will die from epilepsy-related causes. Talk about startling reality. As you see, I consider my all professional engagements, including this presentation, as a big advocacy effort, because I like to consider myself as an avid advocate for people with epilepsy. So, for the young in the audience, I know you are who are trained neurologists. You all know this gentleman, Sir William Goward, right? Arguably, they say one of the greatest neurologists ever. Yet, in 1871, he had claimed that he controlled seizures of 70% of his patients by using bromide. There is some years since then, right? Well, those of you who are epileptologists know this gentleman, Martin Brody, who shared this stage at some point, is arguably the world's authority on drug studies, at least when it comes to real-life studies. Well, he had never claimed 70% in any of his studies. What am I trying to message to you? The message is, yes, we do have 5 times more medications than when some of us started in the field. Yet, we don't treat epilepsy any better. Or as I like to say, are we cursed with 70%? By the way, many of you probably read recent articles in which Dr. Brody, of course, participated. Some people now profess pharmacologic ceiling, that we hit pharmacologic ceiling, whatever that means in different minds. Of course, I'm going to be talking about use of MEG in treating epilepsy. So just as a reminder, these are currently accepted legitimate options, as you all know, for treating drug-resistant epilepsy. And of course, MEG has a role in surgical treatment options. But before we hit the road further, I said I consider this big advocacy effort. Here is how I personally see current prevailing practice among NAEC epilepsy centers. I believe it's basically limited and surgery-centric. Those of you who know how you fill your annual report, you obsess most about surgical data. And there are some reasons that I indicate here why, right? It is true, surgery is the best treatment for selected patients and only potential cure. But there are some other reasons, right? It provides finality, it's an intervention, you can track outcomes very clearly, and of course it's very expensive, so your institution wants you to talk about it because, you know, they shove millions of dollars in it. But I believe we got to change this. I believe we got to have a different approach. We profess comprehensive approach, yet I don't think we provide comprehensive care. On that ground, I advocate comprehensive and surgery inclusive. What do I mean by that? I mean we should inoculate patients with an idea of surgical option from the very day we deliver diagnosis. I rather propose this conceptual shift so we would not end up 20 years later after they've been burning their brains that they say, why nobody ever spoke to me about EMU Why nobody ever mentioned that epilepsy can be treated and sometimes cured with surgery? So I advocate for including surgery, discussion about surgery across the continuum of the disease, starting with very diagnosis conversation. But that's just to lay the land, right? Since probably none of you are people with epilepsy, you may think of it differently. You may say, would I want to be operated? So we as health providers have to be rational, right? So here's, in my mind, 4 very rational reasons why we should do epilepsy surgery. As you know, we had a landmark trial that demonstrated clearly efficacy of surgery, randomized controlled trial that was stopped prematurely because there was evidence superiority. So we know surgery stops seizures. That's one big reason. And seizures produce suffering beyond themselves, right? Some people proclaim that there is at least 6 different mechanisms how seizures kill brain cells. Wouldn't that be valuable to preserve this highly demanded real estate? It certainly would. So surgery actually protects brain, right? A recent study demonstrated that operated patients have 3 times lower mortality than unoperated counterparts. So we can say surgery saves lives. And if you don't resonate with any of these, although this was from different healthcare system, this study apparently demonstrated that surgery pays for itself. So in my book, these are 4 perfectly rational reasons why epilepsy surgery should be done, irrespective of any emotions. Again, I'm repeating this few times because I can't overstate, of course. But what is reality? People fail at least 7 medications, burn their brains for 20 years, and even after that, the most conservative estimate is we maybe operate 1 in 10 of people who can benefit from epilepsy surgery. And as you see, there are claims that it's even underestimation. So how do we train our youngsters here? Okay? So we say we do randomized controlled trials that provide evidence. Then bunch of bigwigs sits together and define clinical practice guidelines, right? And then we all change practice, right? Looks like there is no enthusiasm. Okay, let's see our reality in epilepsy. We had randomized controlled trial. I already showed this slide. So we have evidence, first class. There was a bunch of bigwigs together defining clinical practice guidelines. And there were smart people checking, did practice guidelines influence reality? They didn't. To the degree that even the PI of the landmark trial, Dr. Wiebe, wrote that it remains still an elusive target. Isn't this startling reality par excellence? So what recourses do we have? We can say improve an attitude, but we know how that goes, right? I'm professing conceptual change, but that doesn't do switch overnight, right? We need to improve customer service. If you read all the studies, basically, referring doctors are unhappy how those of us in epilepsy centers treat their patients, meaning many patients don't come back, doctors don't get appropriate feedback about their patients and such. So let's call it that pejoratively customer service. But what we can do on a much faster scale, we can actually advance identification of surgical candidates. And of course, I'm professing optimizing evaluations using all available means, including MEG. So it is time now to introduce finally MEG, right? MEG is obviously neurophysiologic technique, right? It measures brain's activity as reflected in the form of a magnetic field outside of the skull. It's a non-invasive method, okay? It has superb temporal resolution, as does EEG, of course, right? And it can attain temporal resolution on the order of millimeters, and I'll show you some evidence for that. Now, many of you have heard the term magnetic source images, or imaging, MSI. Well, strictly speaking, that is one form of MEG, where we basically use equivalent current dipole as a model and put models of the sources on patients' MRI. But as you will see some slides later, there are other forms of using MEG. So MSI is one form, even though in literature that's frequently used as a synonym for MEG. So don't be puzzled with that. Currently, in this country, approved indications for MEG, meaning something you can bill for, are epilepsy localization and number 2, pre-surgical mapping of eloquent cortices. So let me show you this in a broader context, okay? Let's plot temporal, spatial resolution of all techniques we used and their invasiveness. So what do we know? This is our beloved EEG, right? It has high temporal resolution, but scalp EEG obviously has a very low spatial resolution. SPECT, on the other hand, is on the other extreme. It has bad or low temporal resolution and relatively high spatial resolution. And let's not waste too much time, but let's go to the gold. In this golden quarter, golden corner, this is where invasive EEG and MEG sit. Of course, the difference is MEG is non-invasive. We have some youngsters in the audience. I have to remind them of some currents and all of that. After all, this is epilepsy and neurology grand rounds. But we'll go straight to the point. Where are MEG signals, and for that matter, EEG signals, generated? They are not generated by presynaptic potentials because they are weak, and their symmetric geometry is conducive to cancellation. These are, in fact, generated by postsynaptic potentials that are much longer and thus conducive to summation, temporal summation. So what MEG measures? It measures reflections of intradendritic postsynaptic currents. I like to talk about not only complementary nature of MEG EEG, but I like to talk about their inseparability. So we all will have to go now a little bit back to elementary school, okay? What do I mean by that? Here's what I mean. So you see, the globe is levitating in the air without contact. Important inference is MEG sensor don't have to touch the patient to record brain activity. What you also see, I'm holding cord of my computer, it's working perfectly, and it tells you that electricity is directed by the medium. Unlike magnetic signals, as you will see, I will be placing the thickest piece of PVC between the globe and magnet. Yet, even though I stopped it physically, globe is levitating. What does it tell you? MEG is looking at the brain like there is no surrounding tissues. They don't distort and affect MEG signals. Now again, back further in elementary school, you know, when DC circuit closes, the arm of the compass gets affected, right? But if that wasn't enough for you, please don't forget, we live on a magnet. The Earth is about 50 million times stronger magnet than brain signals. So you all may remember again from elementary school that there is the right-hand rule that governs relationship, geometric relationship between electricity and magnetism. Based on this, MEG and EEG are looking at the same reality under orthogonal angle. So let's go further and apply right-hand rule to the patch of this cortex acquired on 7T. And let's extrapolate this patch of firing cells. And let's say their mean geometric vector is parallel to the skull. According to the right-hand rule, right, MEG signals will spread outside if they summate sufficiently. Sufficient summation is attained if about 10 to 4 to 10 to 5 cells are firing simultaneously. MEG sensors will pick up MEG signals, but there, of course, will be corresponding volume currents that will be reflected in potential difference that is registered by EEG, right? Now, this is what we call tangential source. Tangential source has mean geometric vector that is parallel to the skull, and these sources represent about 70% of brain sources. On the other hand, radial source in blue is one that would be orthogonal to the overlaying skull. Magnetic fields associated with these sources would not penetrate to the skull and would not be seen by MEG. Now, what's important? MEG and EEG are best when combined. And as you will see a few slides later, debate which is better is, in my book, an obsolete and outdated debate. But let's make one more point here. Let's represent this patch with a dot, as we frequently do. What will happen? Electrical signals will be distorted by the medium. MEG signals get out unaffected. Now, yes, quantum physics is applied to basic principles in sensors that are used for MEG. They're called SQUIDs, and not those that you would eat. It stands for superconducting quantum interference devices. They are considered by some most powerful measuring device ever invented. They work on principle of superconductivity. What that means, current flow, state of current flow with no resistance. To attain that, they have to be cooled to almost absolute zero. To be exact, it's 4.2 Kelvin. As you know, 0 Kelvin is absolute zero. But there is practical consequence of it. We have to immerse them in a sea of helium, as I call it, and that means you will end up with about $70,000 bill, depends where you practice and who is your supplier of helium. This is in the era before recycling systems that are part of latest MEG systems. So, I told you, if you live on a magnet, or as I like to call it, we live in magnetically hostile world. We have super sensitive sensor, they'll be super sensitive for everything, right? So we need to isolate patient and the system, and we put them in this box in the room called magnetically shielded room. One that we have does so-called passive shielding, meaning basically repelling hostile magnetic fields of the environment. And there is also an active shielding room, such as one used, let's say, in Cleveland. And several $1 million later, you have your favorite toy. All of those that you can see now look like one of these. However, this one on the left has been only one made actively over the last 10 years or so. And it is changing, as many of them are. This one appears to have resurfaced on the web, digital world. I have never seen one yet in real action to be like that, even though a system of that brand is, for instance, at the NIH. Now, Elekta got rebranded, and these are newcomers since last year. So MEG field is getting crowded now. However, latest development is, looks like York acquired MEG operation of Elekta, Neuromag, and maybe taking a lead. So it's going to be an interesting market, and if anybody wants to discuss that offline, we can do that. But let's say you have your patient and you are wondering, how do I prepare my patient for scanning? Well, humans, look at us here. We all have tendency to decorate ourselves with various things, right? For reasons or for no reasons. Simple, practical advice. Whatever you are not born with is not welcome in the MEG system. That is the safest advice. On the other hand, patients, as we all know, come with various kinds of implants. Most of them cannot be removed, inactivated, or something. So there are ways to fight them, and MEG techs know that very well. And there are also ways to clean data. Notorious situation is you acquire MEG on somebody who has a VNS. These are some tracing that you can't make any sense of, yet after cleaning them with dedicated software, you get perfectly readable tracings. So now, really in a hardcore concept of MEG in a very simple terms. Physicists actually solve this, what's called forward problem, meaning if you know the source, you can calculate exactly magnetic field. But that's not our problem in medical field. Our problem is exactly opposite, right? We have a recording, and we are trying to infer sources. We are trying to estimate sources. Problem with this problem is that it's ill-posed. There is no unique solution. Yet, by engaging in this exercise, we can get very useful estimates that are clinically useful. Here's exactly how we do it. We basically, in MSI example that I explained earlier, we model source as a dot. Of course, dot is not real. It's artificial concept, right? Then we model head as perfect sphere. And by engaging in this exercise in computational assessments, we can get clinically greatly useful results. On the left, you see measurement. In the middle, you see model that was accepted. It was accepted because after some time, it was established that residual, meaning unexplained field, is on the right. So basically, you can see 95% or more of the field is perfectly explained by this simple model. You know, wonder, so, okay, how really accurate can MEG be? In this foundational study, when they placed artificial dipole, they could pinpoint it with about 2 millimeter accuracy. More realistic studies glean 3 millimeters accuracy. And then, as you see, 80s were era when foundational work in MEG was done, right? Luca Romani and his group, when they did tonotopic organization, studied tonotopic organization of auditory cortex, they were able to separate sources few millimeters apart. And then, enormous amount of work from Rita Hari and colleagues from Helsinki studying somatosensory cortex. They also attained accuracy of few millimeters. So what does it all look like? This is, of course, an EEG. We are all familiar with that. And what do we see? We see a bunch of spikes, right? What do we see in MEG? Well, realize, for instance, we are using a system that has 306 channels. I cannot show you 306 channels, so I'm showing you subselection of temporal leads. What do we see? Temporal sensors, better to say, for MEG. We see the same spikes, but what else do we see? Many spikes in between that are not seen by EEG. You see how they together provide complete picture of reality. And then, as I stated, we engage in this activity where we basically identify spikes, we explore their topology, we explore their field, and then finally we do source localization and project it on patient's MRI. What does it look like as a final product? It may look like this. This would be what's known cluster. And as you see in this case, it's left temporal cluster with horizontal orientation that basically points to anterior temporal lobe as most likely source of this patient's seizures. However, reality is much more complex than that. This is proven bilateral case that was referred from Yale. However, what you need to know, latest trends in MEG world lead to applying and validating other methods. So they can look like fMRI, PET, or whatever you want. And we in MEG field believe that actually appropriate, or as I like to call it, accountable application of all of these methods will expand use of MEG. Remember me already saying, priming you, right, for this is a single slide that I'm dedicating to this topic. I think this debate is obsolete. I think we exercised it and learned a lot from it. There are these 6 scenarios that Dr. Ebersol defined, when one versus the other and such, but we all agree. Best, highest yield when used combined. And there'll be actually update on this, so stay tuned. Now, you can say, okay, what is actually evidence that MEG does anything for real humans, right? Well, take this study that basically came up as I entered MEG field. 455 patients, largest series published ever. But what is the bottom line? 35% provided information that was additional to what's previously known, and in 10% it was crucial, meaning decisive for the care of patients. Now, a gentleman who did a lot of MEG studies, the leading researcher in the world, is Robert Knowlton. And of course, he compared everything against gold standard, right? And we know what gold standard is. In this study, he basically demonstrated positive predictive value of MSI, magnetic source imaging, being 82 to 90%, depends on comparison. So if you had positive MSI, you had chance 82 to 90% to capture localized seizure with intracranial monitoring. He further honed on this predictive value of MSI in larger cohort of 160 patients. But as we as American Clinical MEG Society were struggling to get MEG reimbursed, this cardinal study came out. Even though it's not the largest, as you see, it's only 69 patients. It was prospective. It was blinded, crossover study. But what is the bottom line? MSI provided non-redundant information in 1/3 of cases. That's where we crossed Rubicon. That's where insurers said, okay, now we surrender. And good Dr. Knowlton went even further, using his previous cohort of 160 patients, but now involving other methods in his further efforts to improve our gold standard and then compare everything with it. Everybody's favorite invasive method nowadays is, I suspect, SEEG, right? When was last time you guys did any grids? Okay, but you know, anyway, SEEG is now blooming in America. Well, it's befitting that this study of 50 consecutive patients actually compared how MSI and SEEG compare. What is moral of the story? If neurosurgeon resected MEG cluster, there was statistical association with seizure freedom. That was not the case with SEEG. And of course, authors further elaborate how, clusters should not be ignored, how SEG should be informed by all priors, including MSI. Now, some of you may have heard this term clusterectomy, meaning removing areas containing MEG cluster, of course. Well, let's just hone on this little study that showed clear statistical association of removal of cluster with seizure freedom. Now, where do we have most challenge? Well, we have most challenges with, obviously, non-lesional epilepsy, right? Yet, as you can see, when intracranial EEG and MEG are concordant, a chance of seizure freedom is 3 times higher. 3 times. And of course, it was statistically significant. So, on this beloved topic on the gold standard, right? We have to have standards, right? We have to have reference frame. But we also have to understand flaws of the reference frame that we are using. So somehow we became completely content. Gold standard. You remember, all prior MEG studies I quoted to you, and this is just a speck of MEG studies, were comparing against gold standard and trying to improve gold standard. Do you see any irony in it? We know that reality is shades of gray, right? So what do? We use all priors to improve gold standard. And of course, some of us use MEG, not everybody. And then we engage in this exercise where we compare everything to that very gold standard. Isn't this sort of rationalized irrationality that we somehow believe that any part can grow to be equivalent to sum of all parts? Do you find that puzzling, at least, to be politically correct? So, if we want to work on improving that flawed gold standard, then why don't we use all tools available for its improvement? Are we neglecting some tools, obviously? And then in that case, even questions are flawed, obviously, but at least we can ask questions more legitimately because we introduced all priors known to improve gold standard. Now, I don't want you to take MEG and my obviously enthusiastic push for it blindly. I want you to consider some things. For instance, if you postulate based on semiology that you have a case of multifocal epilepsy, and let's say MEG provides you single focus, you have to be very cognizant of MEG's limitation. For instance, if there is deep singulate source, MEG may not be sensitive to it. So may MEG pick up just one source to which it's sensitive, or may even provide you some propagated activity. Likewise, you postulate single focus, and MEG gives you few clusters. Does it guarantee it's multifocal epilepsy? No, it doesn't. Because again, MEG may bring up clinically irrelevant population of spikes or may pick up propagated activity. And that's where competent interpretations come into play. Of course, very important issue in the MEG field is MEG variants that are not clearly defined. And we are working on that. Those MEG variants are probably frequent reasons why we see so many bilateral MEGs. Because there is now emerging pattern, and there are 3 categories of MEG variants, but that's for another day. Now, when I started in MEG field, it used to be a dogma. If patient doesn't have spikes on EEG, don't send them for MEG. I have news for you. That's wrong. According to some studies, up to 47% of patients who have clean EEG may have spikes on MEG. Okay, well, after all, it's neurology grand rounds, right? What kind of neurologist presents with no case? Well, I'm going to give you two extremes. And I'm going to go lightly because we don't have time to go in depth. But this young woman, it's never good to get epilepsy, right? But when you are 16, when you want to start driving, it's really crushing to second, right? And this is what happens to this young woman. And she was really pushing for surgery. However, she has tuberous sclerosis. And you can discern, without being a radiologist or even trained, about 10 different lesions. She underwent EMU evaluation, had 5 left temporal seizures. Neuropsych testing demonstrated that she was impaired in all domains. SPECT was unsuccessful, and I have no clue why one of my colleagues even ordered PET, because PET was to be predictably multifocal, right? But, you know, we epileptologists are obsessive compulsive, so we do things, right? So she got and was MEG'd. And then I had to struggle how to reconcile this. She has left temporal lobe seizures according to EEG, yet I see big cluster on the back. But by using EEG together with MEG, I was able to establish that all this cluster on the back is actually asymmetric and pronounced posts and not epileptic spikes. So, by interpreting this competently, we basically established new reality, if you will. She was gridded, no need for details, and this was followed up in 2013. So, life was different, right? Well, but life is unpredictable. We are all grown enough to know, right? She was now older. After 7 years of seizure freedom, she relapsed. And she comes back equally determined she wants another surgery. She was sent for another MEG. I did, and I'm like, whew, wow. But then I said, okay, let me see, what did we do all these years back? I go back to her 2007 MEG. I overlapped with post-op MRI. Don't these look identical? Well, they are not. I'm not cheating you. Look, here they are overlapped. What is the moral of the story? We disrupted the network that led to seizure manifestation. We actually didn't remove focus in the first surgery. Well, again, she was gridded and all that deal, operated, and she again attained seizure freedom now for 1.5 years. So we bought her about 9 years of high quality life. Now, if you use MSI, magnetic source images, and re-review your MRIs based on that, there is up to 50% chance that you will identify some lesions that were missed. That's literature and review of literature that I did personally. And here's another case. Yes, we struggle with non-invasive cases, but this is more than that. This is case with purely normal MRI of any kind. But, of course, normal PET. However, fortunately, I have a colleague, Dr. Julie Pan, who does research using magnetic resonance spectroscopy. He studied this young gentleman who was 23 years old, and she found basically spectroscopic abnormalities in this parietal area. When I did MEG, they exactly overlap. So not only that MSI can bring to our attention previously missed lesion, it may be pointing not only to obviously abnormal neurophysiology, that's what it does per se, but also abnormal changes in the tissue that we cannot see with conventional MRI methods. Based on this is one of take-home messages. We gleaned 10 common evidence-supported indications for considering MEG. I'm not saying just order MEG checkbox. I'm saying consider MEG. Okay? Of course, if you have lacking or imprecise hypothesis, that is no-brainer. Negative MRI, and you have presumably temporal lobe focus that you hypothesized. According to some studies, MEG will pick up 85% of those. Multiple lesions, could I demonstrate better than I just did in the, case number 1? Large lesions, please think topologically in the brain, particularly if it's lesion that cannot be removed completely. It does make big difference how neurosurgeon approaches and where the focus is. Diagnostic or therapeutic reoperations are notorious example when your EEG cannot serve you, right? Because you get misleading localization or cannot localize. If you have ambiguous findings on EEG, and I could show you great examples, interciliar onset, interhemispheric onset. By the way, MEG is sensitive up to 75% or more to some interhemispheric sources, and some even claim 100% in certain locations where EEG completely misses. Of course, insular onset is a very frequent reason of failure of anterior temporal lobectomy. Again, I already mentioned spikeless or normal EEG is not contraindication. It's in fact reason to refer for MEG because, as I mentioned, 47%. Now, what should you expect from MEG report? That always has to include MEG EEG that are done simultaneously, EEG interpreted competently by clinician, and of course waveform characterized and such. Now, of course, model worthy, as we call it, jargon word coined by Dr. Ebelsor, sources should be modeled, and of course that combined interpretation has to be done by trained person, and that trained person has to be physician, to put it very bluntly, because it's not the case. Obviously, impression about abnormality as we normally do. And again, report has to be signed by clinical magnetoencephalographer that in my mind is physician. Your report, not only that you have to receive PDF or whatever nowadays we send, you have to receive disk that you can import in your DICOM packs, and that you can share with your colleagues at surgical conference, and you can do all sorts of multimodal integration, and you can see here very clearly everything known to man done and co-registered without any issues. And we could spend a good number of minutes talking about this case, but this is just for illustration of how you should receive your MEG. Just one slide on this topic. MEG is used for pre-surgical mapping of elephant cortices. These are just examples of studies where it was demonstrated in clinical context. And we recently proposed even algorithm for language lateralization using MEG. So here's a question. I started with not so benign neglect. So how much really clinicians use, right? Because as you see, some of us have tendency to make these claims, right? And they are somewhat based on the literature, but as you know, not all literature is based on facts, believe or not, right? So if you attended an AEC meeting, this data was presented with percentages, and all numbers in different colors are result of my little arithmetic based on these percentages. So what do you see in the left upper corner? You see that 33% of implants did not lead to resections. So 600 and some patients, their brain was invaded with no useful results. Wouldn't that be a situation where you want to consider all priors, including MEG? Actually, NAEC asks its members, do you have access to MEG? And these are all for this given year, and what you can see, access to MEG is claimed by basically 1 in 5. That's what it boils down to, 1 in 5. Wouldn't you conclude from this that it's not used really that widely? I hope you would. But we went further. We wanted to investigate. And some people say, if you want to know how people feel about something, ask them. You may have some reservations towards that method, but we actually did this survey under the auspice of American Clinical MEG Society. And this is just a little speck of gleaning. Data is being analyzed. We are trying not to overanalyze and trying to really get balanced gleanings from it. So what do you see here, number 10? How many MEG epilepsies were ordered? 717. How many phase 2? 1,043. So at least 300 of implants did not include MEG. Some people made audacious claims that every level 4 center should have MEG. I think that's utopia. But should every patient whose brain is going to be invaded get MEG? I would say yes. And if it's my brain, I would want it done. Unless there would be rational reasons not to. Talking about not using or using MEG. Out of 70 centers who participate, 67 provided data how many MEGs they ordered. What do you see? Isn't this as skewed as it can get? Well, if you take top 15 centers, pretty much nobody else does anything. Isn't that startling reality? And all these people claim that they can handle most complex cases of epilepsy. Would you want to go there? 37%, 25 out of 67, did not order single MEG in that year. But what we really are after, we wanted to understand what motivates people while they use MEG. So we asked them this question 13. To what degree might the following factors influence? And on we went using this Likert scale. Well, these data are not easy to analyze, so I had to collapse them. So what did we do? Me being obsessive compulsive and always struggling to get reports on time, I thought that timely reporting would be more important. Look, directors of epilepsy centers didn't think it was that important. I thought if information is provided in a better way, yet again, almost half of them didn't feel it has any importance. Now, one of my colleagues proposed, let's ask them if participation of magnetoencephalographer in a conference would increase use. So there is somebody on the spot whom you asked to interpret and incorporate. Well, that didn't pan out. Well, then, are you surprised that basically doctors didn't feel they need to know more, right? Did you ever meet a doctor who doesn't know enough? Okay, I'm being too cynical, I think. Obviously, this study has limitations, right? We used questionnaire that had no validation. Sample wasn't random. It was self-selection, whoever responded to an email. Question of anonymity. Survey was anonymous for us, but if you as receiving director, you may say, how, they are tracking me nowadays. It's digital age, right? Well, we didn't track, but that doesn't mean that they didn't feel invaded. And then what is really practice and what is declared, there's no way to prove that unless you would audit everybody. And then there is this social disability factor and subjectivity. Because we ask people, if you don't know exact number, can you give us an estimate? So let's come back to our epilepsy world. I spoke a lot about MEG so far, but I didn't tell you where does it fit in the algorithm, right? Well, we all know how people are evaluated, right? You are here in major epilepsy center, so if everything is concordant, patient goes straight for surgery. But we are not worried about those. We are worried about these on the right, where obviously you have non-lesional cases, right? You have discordant information, you have multi-lesional situations, and any of these listed confounding factors. Of course, that's where you engage in all other priors that you can get in your institution, and that's where MEG would play a role to rectify these ambiguities, and then next steps are pretty much similar in every center in America. So you may recall this article, and wouldn't you think, in addition to selecting surgical candidates, that it would be great to understand better surgical failures? And let's think, can MEG help us with that? Well, this is how Dr. Nagy divided surgical failures. Early, certainly MEG can help, identify mislocalized epileptic focus. If mapping was inadequate, MEG per se is mapping tool, it can help. If there were multiple epileptogenic reasons, I already demonstrated that. And also in identifying functional cortex within, epileptogenic zone. So at least in this big chunk of failures, MEG could teach us a lot. I'm reasonably sure we could debate positively for this other side for late failures, but let's leave that open. I don't have facts. So I wanted to share some conclusions with you that I hope I supported by facts. First one is, MEG is a great localizing tool that can provide otherwise unobtainable information in up to 1/3 of patients with drug-resistant epilepsy going for epilepsy surgery. I mentioned how it can localize eloquent cortices, although we did not talk about that extensively, but it's important to keep in your consideration. I believe, even with this speck of studies that I presented, that MEG improved and continues to improve surgical treatment of epilepsy positively. And we have hundreds of studies proving that. Despite of this overwhelming evidence, I believe that I also provided you support for my claim that it's really underutilized. However, I'm not an idealizer. I wouldn't want you to idealize this technology. I think the best chance for its true role in clinical practice would stem from understanding MEG's clinical potential, its realistic limitations that would be the foundation of realistic expectations. That is, in my book, prerequisite. Now, I said my entire presentation is my big advocacy effort for patients with epilepsy. I hope I focused our minds on reconsidering pre-surgical evaluations of your patients. And I hope you consider MEG. Now, I'm not that young, obviously, right? And dare to say I'm not that naive. I doubt we reach this degree of collective collaboration and harmony. I do want to warn you that by now, between our start and now, 5 people died of epilepsy-related causes. With everything I presented, I do hope that all of us can, in realistic sense, agree that neglecting all available and proven improvements in evidently an imperfect process and float gold standard as we treat our most demanding and challenging patients is not exactly benign. Thank you very much.
Thank you so much for the outstanding talk, really. We have some questions. Probably the most urgent question is that because, so it goes from physics to clinical utilization, right?
Yeah.
Because the MEG and EEG look at things from orthogonal angles, it follows that the percentage of spikes that are missed by EEG and detected by MEG is also equal to the percentage of spikes that are missed by MEG and detected by EEG. Is this true, and does this explain your recommendation that we combine the two studies?
Yes and no. I would not use term equal. It depends on situation. There are situations when EEG is going to underperform, and there are situations when MEG is going to underperform. The degree of underperformance varies with clinical situation. If the sources are preponderantly tangential, MEG is going to be superior. If sources are preponderantly radial, then EEG is going to be more successful. Now, there is big debate in the MEG field what exactly it means and what proportions of realistic sources in the brain are truly radial that MEG doesn't see them. Because some debate, is it maybe 15 degrees or less or something? I wouldn't engage in that debate because we didn't touch that. But what I'm saying, it is specific to the given clinical scenario. Each can fail, each can dominate or outperform the other, but what we know, entire clinical reality can be depicted only by combining these two complementary methods. That's the bottom line. Okay,
perhaps the percentages of one of spikes missed by one and detected by the other may not be equal.
Exactly.
Because the part of the gyrus that is parallel to the scalp, to the skull, may be smaller in overall area than the other deeper, than the sulci.
True. We believe that most realistic sources contain both components, that are very rare sources that are exclusively tangential or exclusively radial, because reality is very complex, right? And then you have to realize we are using sphere as model currently. Now there are realistic head models, and there is whole upcoming field of electric source images that has its own challenges because physics are different. So we shouldn't be bundling them indiscriminately, but yet that does not take anything away from very foundational claim that truly as electricity and magnetism are inseparable. Likewise, the fact that we neglect MEG signals by recording EEG, or those MEG centers who really don't do good service by doing only MEG with no EEG, they're just neglecting EEG. EEG signals are obviously there. Right. Doesn't make it right.
Another very important question is, why is it important that clusterectomy be performed for good surgical outcome? After all, what we're looking at is intraictal epileptiform discharges rather than seizure onset zones. And obviously, as many publications have demonstrated, the irritative zone need not always overlap with the seizure onset zone or the epileptogenic zone.
Very legitimate question. My personal explanation, based on reading obviously literature and some experiences, first we should start by basically touching on how one defines cluster. For instance, there are studies where cluster is defined 5, There are studies where cluster is defined 10, right? Models of the sources on MRI of the patient. And there are studies where it's just kind of loose term. Let's start from the back. All MEG studies agree. The tighter the cluster, if that area is removed, the higher chance for surgical success. The way I interpret that, since we don't take basically area that is covered, because sometimes there is spread, we don't get that as an indication or how widespread is epileptogenic zone or something. No, we believe it reflects source complexity. So basically, my personal belief is when you have a tight cluster, those foci or that focus, that is most frequent route where it gets manifested. Okay? If you remove that area, obviously there is no symptoms, there is no manifestation, you basically disrupt network. I don't always think of that as, oh, you removed the entire focus. Remember that case of tuberous sclerosis, right? Lady was 7 years seizure-free. It's great surgical success. Yes, then 7 years later, she relapsed. Now, this is not completely solved issue, obviously. I am just basically sharing my personal interpretation of this.
Can you comment, I think you mentioned this, but can you comment further on the fact that spatial resolution of MEG is close to that of intracranial EEG?
Sure. Obviously, we know all these 4 studies that I showed you, those were perfect case scenarios, even though they were, some of them were realistic, like tonotopic organization of auditory cortex, somatosensory system. You have to realize when you study those, you can repeat auditory stimulation or somatosensory stimulation 1,000 times and you get signal to noise ratio that is perfect. When we deal with real scenarios, I would not take things lightly. So I always convey that one should not say, okay, here's where I see cluster, that is exactly where the focus is. That's why we all who practice accountably, as they call it, MEG, we always say it has to be placed in the clinical context, and that's why we insist on competent interpretation. We insist that clinical neurophysiologist or an epileptologist, because what you unfortunately can get from some centers, that somebody who is not an MD, who basically signs report that is very generic and not really clinically driven, more technically driven report. So to answer question, yes, there is localization accuracy that I don't think is questionable. Now, is every realistic case going to lead to a few millimeter accuracy? Of course not. And what we also know, deeper the source, mislocalization is going to be bigger. Error in localization is going to be bigger.
This is a related question. Do you implant with stereo EEG the areas of the
Yes.
clusters?
Yes.
Invariably.
We in our case do. Yes.
Yeah, and then have you? This would be probably, I don't know if somebody studied that or if you
Yes.
did. You know, to look at the incidence of seizure onset zone being
Yes. Actually,
overlapping with the cluster.
yes. Some studies that I quoted, I didn't go into detail. Some studies actually addressed even that. And there is very strong evidence that really one shouldn't take clusters lightly. However, let me give you an example when cluster should be taken at least with a grain of salt, if not lightly. Yeah. Let's say we know there are three groups of benign variants. Okay, those are intracilian, supramarginal, and perirolandic. Mm-hmm. So frequently you get this cluster over, sensory motor cortex, and you look at it, gee, this does not fit with anything. Why? Well, that's because we pick up, mu or something that is related to sensory motor cortex, has nothing to do with epilepsy. Yet, you get fit. It's perfectly tight cluster. But then, when you consider topology, when you consider orientation of the sources and everything else, you can say, okay, like an example when I use the EEG to exclude that posterior cluster that were asymmetric posts.
Yeah, makes sense.
Yeah, I just have a few quick questions. So for when you do the MEG, how often you see during like a, I don't know, 1 hour or half an hour MEG scan, how often you see a seizure there, or if you see the seizure onset?
I am actually smiling because Dr. Kobeshi saw big selection of my slides from which I removed slides on this. Okay, I'll tell you exactly. So in my personal experience, without going into arithmetic, I would say, depending on population, 5% in adults and about up to 10% in my case of children, will experience seizure during 1 hour study. Now, study from Cleveland Clinic demonstrated one series when it was 19.1%, and then study from Finland demonstrated 11.3%. Now, there is big difference in studies. Studies from Cleveland were on average 50-some minutes. Okay? Studies from Helsinki were actually up to more than a day. That is just something that is not feasible in this country. We would not have resources to have somebody sleeping in MEG and all of that. So we do see seizures. They are valuable. Sometimes problem is that a patient may have lots of artifacts, and it may obscure very onset, and you have to be very careful. Actually, dealing with localizing epileptic seizures requires more expertise than routine spikes, because you can be easily fooled, because you pick up later when it becomes rhythmic, you localize, and it is, yet onset is 10 seconds before you miss the train. So yes, we can localize. I would say from experience and literature, about half of seizures that we see, or sometimes more, depending on types of seizures. If those are, let's say, focal temporal lobe seizure, patient has behavioral arrest. Well, that's not going to cause artifact. But let's say somebody has frontal lobe epilepsy. That's going to cause artifact, right? And you miss the train.
And another thing is like sometimes the scalp EEG, those sharps, it's very hard for us to say whether it's epileptiform or not. For example, it's small spikes or sharply contoured. I wonder when you see the MEG, whether it will help you to kind of...
Ambiguity is sometimes even bigger in MEG. Because MEG picks up lots of things. You remember that tracing? I showed you an example. There was plenty of spikes, and you would say, well, that's all. There can't be any more, right? You have spike every second. Yet in between, there were MEG spikes that were not reflected on an EEG. So again, this is where it all requires taking into consideration clinical scenario and lots, of course, experience and knowledge.
Okay.
We're way past time, but there's a lot of interest. Somebody texted, a friend of ours, a colleague, sent us a question from Niagara Falls saying, can you comment on ictal recordings by MEG?
That's what we were just talking about. Seizures do happen spontaneously. We in our center do not necessarily bring people to have seizures, but they have them. And as I said, in my experience, 5 to 10% of patients, it's more likely to happen in children. Studies that are published report from 11 to about 19% of ictal recordings with MEG. We can localize them, as I said, in a little bit above half.
All right. Well, thank you very much.
Okay, very welcome.